Hello, everyone. My name is Dr. Ashok Agarwal, and I will be your host for the next 2.5 hours. And we are here to welcome you to the next online ART training in Module 5A, which is Overview of IVF and ICSI. Today is Tuesday, May 18, 2021. And this program is made possible by the American Center for Reproductive Medicine at Cleveland Clinic. Again, welcome to everyone. So here we go. This is my short biography. Um, for those who have not attended the previous program, I'm the Director of Andrology at Cleveland Clinic within the Department of Urology. I'm also the Director of Research and very much involved in research in the causes of male infertility. So our program is one of the most active programs looking at the research, focusing our research on causes of male infertility, looking at how we can find solutions that can benefit patients who have male factor infertility. The organizers and the speakers have no conflict of interest. No companies or outside entities were contacted for sponsorship of these events. This program was made entirely possible by the educational support by the American Center for Reproductive Medicine, and the webcasting was supported by David Reichling, David Wolfley from our Information Technology Division at Cleveland Clinic. Thank you to them. The course faculty who you will be hearing today have donated their time for this online training course. Program coordinators you will meet here have volunteered their time for this training. The names, images, and description of products and instruments that you may see in the lectures are used routinely in various laboratories, IVF labs, and these items are not endorsed by the speakers. So today's program, as you have seen, this is called Module 5A, which is basically an overview of in vitro fertilization and intracytoplasmic sperm injection. The program is supposed to complete by noon because it includes the part related to multiple choice. Our lecture component should finish within 2 hours. We have timed it. So the learning objectives today is talks related to essential equipment, supplies, and culture media, protocols for oocyte retrieval, oocyte denudation, and embryo transfer, oocyte characteristics and embryo quality assessment, and important parameters for embryo culture, monitoring, and quality control. In addition, we have two more lectures, one by Professor Hassan Sallam and one by Kelly Athaije Virka. So these are the components of the today's program that you will see starting from in a circle, starting from equipment to oocyte retrieval, gamete quality, embryo culture, expert commentary, and then industry perspective, and a very brief conclusion. Is Professor Hassan Sallam. Dr. Sallam is a professor of OBGYN at the University of Alexandria in Egypt and a director at the Alexandria Fertility and IVF Center for a long time. He is the chair of International Representative Committee of Royal College of OBGYN and a former chairman of OBGYN and vice dean of Alexandria University. He has so many positions that it is going to take a long time, but Dr. Hassan is a world leader in the field of ART. He is recognized, he is been associated with a number of organizations. He's the founding member of several of them, and has connection all over the world. So we are very privileged and honored to have Dr. Salam, who's a great friend of mine and of our program for a number of years, to give the next presentation, which is on the clinical perspective of IVF and ICSI. And we have recorded his presentation to make sure that you are able to hear it. Professor Salam is present in this meeting today. So he is actually listening to us. So let me start his presentation.
Thank you very much, Professor Agarwal, for asking me to comment on these excellent presentations by Christina and Israel. And as a clinician, there are some points which caught my attention and on which I'm going to say a few words. Now, the first point is the trigger, HCG trigger to oocyte retrieval interval. And it is true that as clinicians, sometimes we are late in doing the embryo, the oocyte collection, and we can go to 38 hours and sometimes even to 39 hours. But as said, 36 hours should be the cutoff point because, as you can see here from this study by Bosdo Italia and the group of Professor Talaziz, as you can see, the 36 hours gives us a higher yield of oocytes. There is another study which was published last year, which showed that by this Chinese group, showing that it seems that this interval also is related to the stimulation protocol. As you can see here, the oocyte retrieval interval should be gradually prolonged from the mild stimulation protocol to the antagonist, to the short agonist, to the long agonist protocol. So it seems that if we are using the mild stimulation protocol, we can afford to go a little bit early. And if we are using the long agonist protocol, we can afford to do our oocyte retrieval a little bit later. As you can see from this study, on the left we have the oocyte retrieval rate, and on the right we have the mature oocyte retrieval. Another point which was raised in these presentations is the aspiration needle and any problems encountered there. And as said, the ideal needle is really the 17 gauge needle, because if we go with a thicker needle, we may face bleeding, and we go a slimmer needle will give us a prolonged time for collection, and it may not reach the distal oocyte. So 17 is the ideal size, really. And if we are faced with bleeding, we can always compress with a piece of gauze or piece of cotton in both vaginal porneces. It's not always a good idea to put a speculum and have a look, because the bleeding point becomes a slit and the bleeding increases. Another problem which we may face during oocyte retrieval is the presence of an endometriosis cyst. And the good advice here is to not to aspirate it, because when we aspirate it, we create a vacuum. And once we withdraw our needle, everything in the vagina goes back inside this endometriosis cyst, and we face the possibility of developing a tubal ovarian abscess. So don't aspirate. Try always to go around this cyst to collect the oocytes. And then if we do aspirate, then we have to give two types of antibiotics, at least one for the aerobes and one for the anaerobes. Another point is the necessity of follicular flushing. Well, of course, if we are talking about multi-follicular flushing, as we have heard in the presentation, it doesn't add much. But if we have only one follicle, now this Swiss study, which was published last October, tells us that this was a multi-center study, actually, and what they found is that they obtained 21% of their oocytes in the first aspirate. But then when they started to flush, they got another 23% in the first flush, then 9%, 10%, 4%, and by the fifth flush, they had collected 82% of their oocytes. So it is worth the possibility to flush if we are talking about one follicle. Then another point raised was about the time-lapse incubators or incubator systems. And as was said, there are two types. On the left, we have the cameras which we can put inside a conventional CO2 incubator, and on the right side, you have the integrated systems, which are essentially an incubator with a built-in TLS time-lapse system. And I said, if we are going to use these systems to select our embryos for transfer, now it doesn't add very much. This is the live birth rate. This is the Cochrane review by Armstrong, Italia, showing the two important studies by Carmen Rubio and Park. And again, the end result is that it doesn't add much to the live birth rate. There's also the randomized control trial by Goodman, Italia, coming from the Cleveland Clinic, the group of Professor Thomas Falconi and Professor Ashok Agarwal. And again, if we put it again with this meta-analysis, it is not going to add much. However, we must say that these systems are very good for research purposes. And the other thing to say is that maybe we did not find the proper algorithm yet, because as we know, everybody is using a different algorithm. So maybe we didn't reach the proper algorithm, or maybe that these systems cannot help us really in embryo selection. Another point is the gentle versus the difficult transfer. Is it really true that if we have a difficult transfer, our clinical pregnancy rate is going to be lower? And the short answer is yes. This is a meta-analysis we conducted many years ago, including one of our studies published in 2003. And as you can see here, the clinical pregnancy was diminished to 73% of its origin. So you lose about 1/4 of your pregnancies if we have a difficult transfer. So yes, we have to strive to have a gentle transfer always if we can. And one way that people have suggested is to do a trial embryo transfer or a dummy embryo transfer, as you can see from this diagram, to try and point out the direction of the cervical canal, and also to find out whether the uterus is anteverted, retroverted, or straight. But as you can see, the problem, as shown by Henne and Milke from San Francisco in a publication 16 years ago, they showed that the uterus changes position. When they started with some anteverted uteri, when they came to the actual embryo transfer, they found that these anteverted uteri, some of them became retroverted, and vice versa. Those who were retroverted, many of them reverted to being anteverted. So it is not, some people don't really do the trial embryo transfer. And what they prefer to do is, of course, the ultrasound-guided embryo transfer, which most of the people are doing now. And this is our study published in Human Reproduction many years ago, which showed that the problem really during embryo transfer is at the level of the uterus cervical angle, because this is where the embryo catheter is stuck. And then we have shown that some people don't have an angle in the first place. Some people have a mild angle, a moderate angle, or an obtuse angle, and some have a retroverted uterus, of course. And then this can help us in bending our catheter when we are trying to negotiate our way inside the uterine cavity. And in fact, this is the meta-analysis we conducted many years ago again and published in Fertility and Sterility, showing that yes, ultrasound-guided embryo transfer definitely improves the ongoing pregnancy rate by about 50%, something which has been confirmed after that in the Cochrane review by Brown, Italia. Again, as you can see, the odds ratio of 1.47. And one good idea is to ask the patient to have her bladder full, or at least not to empty her bladder, because this can straighten any angle and makes things easier during embryo transfer. And does this work? And the short answer is yes. This is the meta-analysis conducted by Abu Setta from Canada, from Alberta in Canada, showing that yes, the live birth rate is increased if the patient has a full bladder. Another point which was discussed again is the difference between the soft catheters and the firm catheters. And the short answer is that yes, this meta-analysis by Abu Shat again shows that the soft catheters are associated with a higher clinical pregnancy rate, as you can see here. But the question is which catheter is considered soft and which catheter is considered firm. And the other point is that this meta-analysis includes some studies which were not ultrasound-guided embryo transfers, because if we are talking about firm embryo transfer catheters with ultrasound guidance, then there is another meta-analysis by Prof showing that it doesn't make a difference, because at this under these circumstances you can bend the tip of the catheter according to the angle you see by ultrasound. Another point was the air in the embryo transfer catheter and whether it matters or not. And this is the study by Moreno Italia from Spain, showing here that there is no difference in the pregnancy rate or the implantation rate if you have or you don't have air in the embryo transfer catheter. Another point which brings us to this point, which is the site of embryo deposition. Where exactly should we aim at putting our embryos, depositing our embryos? And in fact, if we are too near to the fundus, as you can see from this study by Corolo, if we are about 10 millimeters from the fundus, the implantation rate was 20%. But when you go away from the fundus, about 15 millimeters, the implantation rate was 31%, and 2 centimeters was about 33%. So it's a good idea to stay away from the fundus at least 1.5 centimeters. Which brings us to another point discussed in the presentation, which is the time between loading and discharging the embryos, and how long can we keep the embryos inside the embryo transfer catheter while we are trying to negotiate our way inside the uterine cavity. Well, the short answer is 2 minutes, and this is the work by Matoras and his colleagues from Spain again, from Barcelona, and showing here that if you stay up to 2 minutes, you're okay. Then the pregnancy starts to diminish significantly, and the implantation rate again starts to diminish significantly. And with this, I've come to the end of my comments, and I would like to thank Professor Agarwal again.
And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ACRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.